Hello, good evening. So this boring part, right? The disclaimer. So I'll read just one line. Images displayed during this medical training session are for education purpose. All right. So welcome to session 26, urinary bladder and urethra, right? In fact, we are taking two topics together. Plus we'll be covering some of the physiology part also. Now you'll find one change today. What I was really thinking is that if we really want to go bit fast, right, so then there are some of the information, I'm using the word information, that it is quite a theoretical thing. So when like say list of ligaments, so instead of me writing all the ligaments name live, today I have done a small experiment. Some of the contents I have written in just first few pages, right, which I'll explain. But the point where the detailed explanation is needed, there will all go live, right? So let's see how it goes. And then that way, if we could really save some time, so that way we can really add some more topics also. So that's the whole intention regarding yeah, Tejas, this is, yes, it is like we'll try to cover as early as possible, because in this week we'll be completing abdomen and immediately we'll be starting with the head and neck, right? Okay, so here it is, the theory part, urinary bladder, right? That's our topic to start with. And it is a temporary storage of urine, muscular reservoir, right? The muscle, the name of the muscle, this is the keyword, that is the detrusor muscles. These are the muscles which are spatial muscles, and they'll be playing a vital role. That would be the location of urinary bladder, that is in pelvic cavity, right? In the pelvic cavity, in the anterior portion, we'll be watching the urinary bladder. Obviously, obviously. So now, oh, you are telling about the physiology topics? I think, okay. What I understood is, say, in case of urinary bladder, yes, we'll be covering even the physiology of micturition, because then and then it will really make the sense that what exactly is autonomous bladder and what is automatic bladder, right? Anyway, so uh, just a suggestion. Will it be okay if I record some of the lectures and then I put it over here and then you can watch it in case of physiology, or the live is better, right? Just let me know. Right now, we'll not be wasting time in that discussion, but let me know in the email that what if I record some of the sessions and place it, or the live is better, right? Okay, so coming back to our topic, this is where when the bladder is empty, it will be within the pelvis, but when it is full, it extends upwards, right? It extends upwards and it goes into the abdominal cavity also, right? So that's the whole difference. Okay, now starts the important portion. Say, when we talk about bladder, we were in during our discussion of spleen, we said we use the word that it is tetrahedral, right? Tetrahedral. Tetrahedral means it is a pyramid shape, but the pyramid whose base is, there is a base and it has got three sides, right? So it has got three sides like this, right? So that's the really the shape of this urinary bladder. So when we say this base, right, there is a base and then there are three sides. So that base is on, here is the base. Watch it. See, that's the base, right? So the location of the bladder would be, this is the bladder on both the sides, right? On the both the sides, this is one surface and then there is one superior surface. So one superior surface and two surfaces, they are on the lateral side. Now these lateral sides, so here this would be the superior surface. Now every surface will be coming in contact with some organ. That is what we need to know, and at the same time we need to know that which surface will be covered by peritoneum and which not, right? And we'll keep on watching its clinical importance also. Okay, so this is top superior surface, and this one would be, actually we say, the lateral, right? Because it is on both the sides, lateral. And as it is inferior, right? So there is superior surface, and then we have got the, say, inferior, inferolateral, and there would be right side and the left side. So right inferolateral, left inferolateral base, and the superior. That's how the whole bladder is arranged. That's the apex, right? Absolutely front. This neck would be very vital because there are so many important structures associated with it. So what we saw, the base, apex, neck, and their surfaces. Now rest of the things are easy. This lateral surface and the opposite lateral surface, when they meet like this, so that forms the anterior border, right? That forms the anterior border. This superior surface and this side, when it meets, so this one would be the lateral border, right? Not very difficult to understand, correct? And this is that famous median umbilical ligament, right? Who gained so much attention yesterday, right? We talked in detail about it, right? I hope you remember that what was it, right? Just to recollect, it was that obliterated embryonic urachus, right? It was obliterated embryonic urachus, right? And what was that urachus? You know that, right? Allantois, the distal part. Okay. And that proximal part which was utilized in the formation of urinary bladder, right? So now things are falling into its place. Okay, regarding this neck, the neck is very important because this is the lowest most, and it is fixed, right? So this is the lowest most part, or the lowermost, or the lowest part, and it is fixed. Now, in case of male, say this is the prostate which is closely associated with the neck, right? And then there starts the urethra. Now, in case of females, the size of the urethra is very small. So that's why whenever the catheterization is needed, it is very fast and very easy. But in case of male, right, there are so many chances of the complication because you will see the entire anatomy is relatively bit complex. So urethra, it starts, it is like an exit from the urinary bladder, and then part of urethra which is before prostate, right? Part of urethra which is within the prostate, part of urethra which is after the prostate. And then again, there will be division. So that is what we'll be watching in more detail, right? Here are the ureters which are entering onto into the urinary bladder, right? This is how we really see from below, right? So from below, this is anterior, so there is apex, that's fine, correct? And obviously this would be the anterior border. How come? Here it is, see, it is this border, right? It is this border, anterior border. So when we are watching from below, that's the border which we really see. Here it is, right? So on both the sides of anterior border, this would be inferolateral surface, correct? This one and this one, that would be inferolateral surface. And that's the neck, and in between from the neck, the urethra is coming out, and these are the ureters, and posterior portion, that is the base, right? So pretty good, right? Now here it is. This image has been put for your convenience. See, this is like urinary bladder, right? This is urinary bladder. Now how is it arranged? This is anterior, right? That's posterior. So it means this portion would be pubic symphysis, right? This is the sagittal section, right? This is the sagittal section. And then we are watching. See, over here, what is really important is posteriorly, right? This is posteriorly. So there is rectum, right? Terminal ileum. On anterior aspect. And this is prostate, right? This is prostate. Perfect, right? And then that's the urethra. That's the urethra. And it is going all the way into the penis, right? And there is name sorry. And there is name for this entire path, right? Urethra is divided into several parts. So that's how things are arranged. This is just for your orientation. And see, there is that suprapubic fat, right? So in case of male, this is pretty easy, but this is how it's arranged in case of female, right? Watch the reference. This one, right? That is urinary bladder. But then that's the uterus, right? That is the uterus. And that's where the vagina, and then the rectum, correct? See, the prostate, in fact, the prostate, they are actually encircling the urethra, right? They are actually encircling the urethra. So we'll discuss this point as we'll see it in when the urethra will come. Just after completion of this urinary bladder, the next topic is urethra for today only, right? So at that point we'll cover that thing. And catheterization is that sometimes when patient is unable to pass urine, or say whenever you are planning any of the surgery, you need to put a tube into the urinary bladder so that urine comes out of that tube. That thing is called as the catheter, right? Whether male or female, but that, so you must have seen that post surgery there is a bag which is hanging below the cot, right? Below the patient. So that is where that urine gets collected, and from there they figure out that how much is the urine output, right? Because that bag is marked with all those markings, so you can estimate that how much urine is coming out. So that's what it is calculated, that is how much patient has consumed, right? Whether it is intravenously or by mouth, and what is the output. So that is the input and the output. Okay, so this is just for the orientation in case of female and in case of male, right? Okay, this part I have already written. So this is where, sorry. Starting with the apex, because apex is easy. Median umbilical ligament, we talked about it, right? It is remnant of that urachus, embryological urachus. Regarding the base is in case of female, right? We just saw that this base means actually the posterior part, right? When we say about the posterior part, right? So in case of female, right, here it is, this one is anterior and this one is posterior. So that means this one would be the base, sorry, that one would be the base, right? This one is the base. And see, the base is associated with what? It is associated with uterine cervix and the vagina. right? Makes sense, right? So this is fine. In case of male, upper part and lower part, right? Let's watch it, right? Here it is. Here it is. Upper part and lower part, right? See how the upper part, how the upper part, right? That is associated with, and what about the lower part? That's where the prostate and everything would come, right? So over here, upper part, rectum, right? That is the rectovesical pouch, the pouch which is between rectum and the urinary bladder. Rectum and urinary bladder. Bladder is also called as vesicle. Vesicle means container, right? Vesicle means container. So that's the pouch. And the lower part is seminal vesicle plus vas deferens, because that's where these things will be collectively entering into the prostate and finally into the ejaculatory duct and into the prostate, right? Varicocele, it is completely off the topic, right? So right now, deliberately, I'm not touching it. We'll discuss all these extra topics, right? Uh, when we'll be discussing, we'll be keeping one session only for that. Okay, because then else we'll be deviating from the topic completely, right? So in the benefit of everyone, I'm not doing it. Okay, so this is like, just orient yourself first for this. This is the posterior portion, right? That is the posterior part. In posterior part, this is a male bladder, correct? Male bladder. Why male? Because see, we can see that ejaculatory duct, prostate, right? Everything. And this is the posterior part. One important clue which you have to pick up is that upper part of base is covered with peritoneum. But that's it. This is the only part which is covered with peritoneum. So it means that if by any means, whether you put needle or you put anything, but if this peritoneum is ruptured, right, that means you'll be entering into the peritoneal cavity, and that is something which you would always like to avoid, right? So we'll see this. This is an important clue that only the superior surface, upper part of the base, that is only which is covered with peritoneum. Lower part is devoid of, right? So this is the ductus deferens, which will be carrying those sperms all the way from their production house, and they'll be reaching over here, right? And it is this seminal vesicle which will be playing its role, and finally they all will be landing into the prostate, where prostate will be adding the nutritional fluid, and things will be drained into the urethra for the final journey, right? So that's how things are arranged. Remember, this is the posterior part. The upper portion, yes, repeating again, it is in relation with the rectum. Neck, we talked about it, that it is the most fixed part. Okay? That's the most fixed part. What really is important is that, see, this is the lowest part, right? Now after that the urethra starts. So this is the lowest part. Now this is 3 to 4 centimeters behind pubic symphysis. Why pubic symphysis? Because pubic symphysis is something which can be palpated, right? It can be palpated. So its surface location is easy. 3 to 4 centimeters behind pubic symphysis is that neck. Now we know this part, that on the top, right? Say if this is the bladder, if this is the bladder, right? That's the anterior part. That's the anterior part. And we know that this is, if this is pubic symphysis, when the bladder is extended, right? That is when the bladder is full, right? It will go up, right? It will go up. So it is this portion which is covered with peritoneum, right? And this lower portion, there is no peritoneum over here. So that would make a big advantage, that in case if anything is to be inserted, right? So over here, once the bladder is distended, you won't be entering into the peritoneal cavity. Regarding, say, this neck, in case of female, pelvic fascia which is surrounding the urethra, simple, right? It is thus the pelvic fascia which is surrounding it. But in case of male, there is something which is very vital, and that is, say, in case of urethra, right? In case of urethra, in male, there is internal urethral sphincter. Internal urethral sphincter. This is not present in females, right? This is not present in females. So in case of female, it is only the distal urethral sphincter which is vital to control the urine, and that's the reason post say delivery, if the muscles are weak, if the pelvic muscles they are weak for any of the reason, then any of the act in which the intra-abdominal pressure rises, that is coughing, laughing, or when they jump, right, that urine starts dribbling. This is one of the very common problem no one tells. But yes, it is a problem. It is simply because those pelvic muscles, right, they have weakened. They are now weak. In any case, because of pregnancy, when the muscles are stretched, they actually lose their some of the strength. But it is like there are very good exercises. In fact, we'll be discussing, right, not for much, but at least for 2-3 minutes, we'll be discussing those exercises. So why to wait? Why not to make those muscles so powerful? They are called as the Kegel exercise or pelvic floor exercise, right? And it's not so that it is important for females. It is important for males as well, because one of the vital thing is that it improves sexual performance, and at the same time, the most important part, that is what is called as the say erectile dysfunction, that is prevented. So what it really does is, say, all those levator ani muscles, all those pelvic floor muscles, right, they become so strong because they'll be playing a vital role into all these intimate functions. At the same time, they'll be playing the role into the maturation, right? Now see, in case of males, I'll just draw this, right? That's the urethra, that's the neck. See, this is the neck, right? That's the neck. Then comes the prostate, right? So pre-prostatic sphincter, right? Pre-prostatic. So can we tell this thing that it is before prostate? So that pre-prostatic sphincter, that is what is called as the internal urethral sphincter, right? Or proximal sphincter, right? So this is acting as this is prostate. This is prostate. So these fibers, right? Let's see in the color, these fibers, they are acting as a sphincter. We'll be talking about its nerve supply, etc., right? And we'll actually see that what's the process of micturition and what is really the importance of this internal urethral sphincter. Okay. So that's how things are arranged. Moving further, regarding the superior surface, which we already say understood, that superior surface, that is where the peritoneum is there, right? And there would be the uterine supravaginal part, right? We saw in that image that when the bladder is like this and the uterus is exactly on its top, so that's where it is. In case of males, well, it is the sigmoid colon and the terminal ileum, so they are over there, right, on the superior surface. Infralateral surface, so those two surfaces which were on both the sides, right? Yes, there is no peritoneum, but obviously we already said that peritoneum is only on the superior surface and some part of the base, right? Some part of the base, only the upper part. So this is that which is related to pubis, retropubic fat, we saw that, and these are the muscles, levator ani and the obturator internus, right? It is, these are the muscles which are so important, right? And in case of say female, it is pubo-vesical ligament, and in case of male, it is pubo-prostatic ligament, right? We'll just see that. See, this is a medial view, right? That's a medial view. Obturator internus, and below this is levator ani, right? That is levator ani and obturator internus. See, from the medial side. So again, the sagittal section taken, and then we are sitting inside and then watching the medial view. So here it is, the urinary bladder, right? Urinary bladder. And from pubis, this is the pubis, right? So there is puboprostatic ligament, and that's the outline of prostate. See, now it is making the sense, right? See, this is the bladder, right? That's the bladder. Then there would be neck, and then it would go in the form of urethra, and at the neck of the bladder, this one is prostate, right? That's the prostate, right? Very schematic diagram, but our purpose is two important purpose, because when we'll be talking about those Kegel exercise, we need to understand that it is the levator ani, right? So important. It is this obturator internus, right? So important for these pelvic muscles, right? Because when you do squats, or when you do deadlifts, or when you do bridge, or the bird dog, right? All these exercises, they are normally, we do all sorts of exercise, right? You'll do the exercise of biceps and triceps and all those things, but these vital areas, they are usually missed, right? And trust me, it won't take more than, seriously, it won't take more than 6 minutes a day, right? Again, I always say it is like an investment. You'll be getting the returns years after. Okay, so that's that was the, right, that is like a bladder, and that's the neck. And when the bladder is distended, right, so that and peritoneal fold will also go up. And whenever you do surgical approach, right, so when the bladder is distended, so there is peritoneum is over here, correct, and that would be the correct surgical approach towards the bladder, so that you don't puncture the peritoneal cavity, right? So it is like save peritoneal cavity. Okay, these are the ligaments of the bladder. Whenever we say ligament in case of abdomen and pelvis, it means we are talking about either thickened fascia, or we are talking about peritoneal folds, right? They are the ligaments. So again, in that there are true and false, right? True and false ligament. So true ligaments, they say that yes, we are really much tougher, right? So they are like thickened fascia. Those false ligaments, they'll say that we are just peritoneal folds, right? So when we say peritoneal folds, so those umbilical folds, yesterday we saw that, right? That umbilical folds, there was a median umbilical fold. So what is fold? There was medial umbilical ligament, which was remnant of that embryological urachus, and on that, because it is a tough structure, right, and on that there is peritoneal fold. That peritoneal fold is the median umbilical fold. So whenever we talk about fold, that means there is something underneath, and on top of it peritoneum is reflecting, right? So that is median umbilical fold. When those umbilical arteries, they are obliterated right and left, so we have got right medial and left medial umbilical fold. So underneath there was that umbilical artery, right? So over here, these are the false ligament, so lateral and the posterior. So this is like paravesical fold, right? Paravesical and sacrogenital folds. Regarding this part, when we'll be watching the reproductive system, right, from tomorrow and day after tomorrow. So one day we'll take the female reproductive, then the male reproductive, and finally the last topics. So at that point, these folds will be making more sense. Let's come to this true vesicle, where we know true ligaments, right? Thickened fascia, lateral true ligament, okay. Then there is posterior ligament, okay, and there is median umbilical ligament. Yes, this we know, right? That is because of that urachus. And there is lateral and medial puboprostatic, okay. lateral and medial puboprostatic. Now this looks crazy, right? Let's have a look at the figure where it will make more sense. Now these are the true ligaments, right? But watch it. Here it is cervix uteri. That means this is female, right? But in any case, we need to see those true ligaments. True ligaments means they are thickened fascia. First, see from urinary bladder, because that's the topic for today. Correct? So here it is urinary bladder. And from urinary bladder, here goes the first, that posterior ligament, right? It is going posteriorly. So here it is written, right? It is posterior. That this one is anterior. So this is posterior ligament. And those who are on side, they are going lateral true ligament. Fine. From pubis to bladder. So that is what is called as the pubovesical ligament from pubis, because this one would be the pubis, right? So pubovesical ligament. So pubovesical, lateral, and the posterior ligament. That is done. See, when we'll be discussing the veins, at that point, this thing will come into picture. That is, these venous plexuses, they are into posterior ligament. All right, right? We'll keep it in the one corner of the mind. Regarding this middle rectal vessels and rectum and lateral ligaments of rectum, we are not concerned. That would come when we'll be talking about the final anal canal, rectum and anal canal. Right? So at that time we'll see. Fine. So this is the posterior ligament, lateral ligament, and the pubovesical ligaments. Okay. This pubovesical, in case of males, it would be puboprostatic. Correct? Puboprostatic in case of males. Fine. Now the picture would be crystal clear, because this image is that image which will be giving us all those concepts which are needed to understand several of the concepts. Friends, we are talking about now interior of bladder, right? And in interior of bladder, let's follow one discipline, the order. First, we just watch this area, right? This area. Now this area, right, it is quite loose, quite loose. There are irregular mucosal folds, right? So I've written one over here. So these are irregular mucosal folds, because there is a muscular coat, and that muscular coat, that is what is called as the detrusor muscles, right? It is what is called as the detrusor muscles. This detrusor is the hallmark of the bladder, right? So they are loosely arranged. So that's why these mucosal folds, they are very loosely attached. They are irregular. So that is one. But see, there is one area which is so, and it is triangular, right? The looks itself is telling this is triangular, and that's why very rightly named trigon, right? In this trigon, this is irregular, right? One, and over here it is smooth, right? The mucosa is smooth mucosa. So that's our second point. Over here, even the muscular coat, right? Muscular coat, that is also firmly attached. Firmly attached. So that's the second part. And that's the ureteric opening, right? So ureteric opening, and they are just opening at an angle into the triangle. So that is ureteric opening. In between these ureteric opening, there is elevation. So that is interureteric ridge, correct? Interureteric ridge. So that's something like this, interureteric ridge, right? This is also called as the base of trigon, right? That is base of trigon. And say there was a person, right, called Mercier. I don't know why they have said, was he drinking over here? But anyway, it is called as the bar of Mercier. Right? Anyway, this bar means it is the horizontal thing, right? Horizontal raise, not that bar. Okay. The third is this point which we need to know. This is internal urethral orifice, right? Internal urethral orifice. So that's the third point. This uvula vesicae, right? Uvula vesicae, this is a small elevation, right? This is an elevation. Why that elevation? Because prostate has got lobes, and one of the lobe is its median lobe, right? It is the median lobe. Median lobe of prostate. So because of that, there is elevation. So that's what is called as the uvula vesicae. Fair enough, right? So this much is done. Finally, the prostate, the membranous urethra, and the urethral crest and the prostatic urethra. The urethra which is into the prostate, that is prostatic urethra, and then further it is the membranous urethra. Urethral crest, all those things, they are actually, say, will be discussed when we'll be talking about prostate, right? But yes, this much is fair enough for this particular figure. Okay, here it is. That's what is called as the cystoscopy, right? Say cystoscopy. Cyst means space, right? So here we are dealing with the bladder, and scopy means to what? So to examine interior of bladder is what is called as the cystoscopy. So via penis, this cystoscope is inserted and there is camera attached, and then it is attached with the light source, and you watch the things on the monitor, right? See the entire anatomy penis, that's the urinary bladder, right? And then entering in, that's the prostate, and then entering into the urinary bladder, right? And see this rectum posteriorly situated. All right, some theory part. As such, the capacity, right, is about 120 to 320 ml. Average is about 220, right? That is the average is about 220. Now, whenever it crosses, there is a very nice mechanism. So because urine is constantly produced, cystoscopy is actually not like ultrasound. Cystoscopy is when there is a direct visualization, right? Where is direct visualization? That means you are putting the cystoscope, or you can say you are just inserting the camera, right? So on the tip there is camera. You are inserting it into the penis, and it is going all the way, and it is landing into the bladder, and so thus there is a direct visualization. I'll try to put I'll try to put one session in which actually I should be able to show you ultrasonic image or CT, MRI, even the cystoscope images, right? Let's see how we finish this thing, right? And then we'll plan one extra session for that, because there are so many things to cover in abdomen. And yes, I know that head and neck, actually head and neck is also very tricky, right? So yes, we'll be dealing with that also as early as possible. Okay, coming back to this, say cystoscopy is a direct visualization, while when you put the ultrasound, when the bladder is full, right, and you put the probe, those ultrasonic waves that hit and then they come back, and what picture you get, that is the ultrasonic image, right? That is like a sort of sectional imaging. When you do CT scan, it is like you are using slice of X-ray. When you are using MRI, so in that case The entire concept is the nuclear concept, right? Okay, so this is average is about 220, but when it comes to about say 250 to 300 ml, that's where the desire to micturate starts. That desire starts. Because till that point, what was happening that when the urine gets collected, because urine is forming constantly, so those detrusor muscles relax, right? When they relax, there is no increase in intravesical pressure, bladder becomes slightly full. Again, the urine starts coming, again it dilates, right? Again it relaxes. So these detrusor muscles, they keep that intravesical pressure normal so that there is no problem. But when there is a limit, at 250 to 300 ml, that desire starts. But still, detrusor, they have got the capacity to relax, and the bladder keeps on enlarging. It keeps on getting filled. But when it is more than 500 ml, then those stretch receptors, they come into picture, and that's where the pain starts. So it becomes painful, right? And that pain, that is, it gives the lower abdominal pain, right? Lower abdominal pain. It starts perineum, pelvis, right? All due to that supply. T11 to L2 and S2, S3, S4, right? That pudendal nerve, they are responsible for these pain sensations. Okay. So regarding the blood supply, right? It is pretty easy. So that's the arterial supply. That's the arterial supply. Starts from internal iliac artery, right? So that's main. So internal iliac artery, right? From that it divides into anterior and posterior, right? So here it is its anterior trunk, and immediately you will figure out, yes, we talked about it. That is the superior and the inferior vesical artery. Correct? Vesical artery. Vesical artery. Right? And in case of females, that would be uterine artery. It would be the uterine arteries. So they are for this arterial supply. This is the main supply. There would be some branches from obturator, and there'll be few branches from inferior gluteal. But as the name suggests, vesical arteries, they are the main supply. Right? Moving on to the venous drainage. In venous drainage, all we need to remember is, I know, right? You know, that was posterior ligament of bladder, because that's it. That's it. That's what. So that is the venous drainage. This venous drainage is very typical. There is a vesical plexus, right? Group of veins, they form this plexus. Where is it? On both the sides of the bladder. Both the sides, they are called as the infrolateral surface. So this is infrolateral surface of bladder. From there, from these vesical plexus, those veins, right? We saw that that was posterior ligament of bladder, right? Posterior ligament of bladder. And through that posterior ligament, finally, so they all will be landing into, as a final destination, internal iliac veins. They drain into internal iliac veins. But that's the key point, that they will be going via posterior ligament of bladder. Lymphatic drainage. Lymphatic drainage. Again, main. It would always go to external iliac nodes. So this is main, right? Partly it will go to internal iliac nodes, plus you remember we saw when we were discussing aorta, so there was few lateral aortic nodes. So here they'll be playing their role. Lateral aortic nodes. Right? Okay. Now for the nerve supply. Now before we really start the nerve supply, right, I would like to draw one very simple figure. Right? Because learning this is important even from the physiology point of view, even from the medicine point of view. So let's say this is a urinary bladder drawn very crudely, right? And that's the urethra. Parasympathetic supply, right? Which would be via pelvic nerves. Pelvic nerves. Okay. So these parasympathetic supply, what would they do? They would contract detrusor muscles, right? And they will tell that was that internal sphincter, right? Now you don't put any resistance and you just relax. That means this is responsible for micturition. True. Though we'll be understanding and discussing micturition the entire process, but this is his role. For the for the sympathetic one, right? There is hypogastric. Hypogastric. So this will be giving sympathetic contribution. Now, this is important for one purpose. Say in urinary bladder, right? In urinary bladder, it happens like, say, there would be, say, even the semen would be coming, right? This sympathetic, will see that will this sympathetic system, that is important because it prevents reflux of semen into the bladder, right? So that's the important part. Otherwise, for the micturition part, there is no significant role. Over here, this is external sphincter, right? Straight away the external sphincter. We are not right now talking about internal sphincter. This is the external sphincter. This external sphincter is somatic, right? Its supply is somatic. Somatic means this is under voluntary control. This is under voluntary control. So till the situation is comfortable, still the place is fine, this external sphincter will put immense pressure so that none of the urine comes out, right? So this is somatic, right? And that is via pudendal nerve. So that is via pudendal nerve. True? So only during, say, its function is keep this contracted, right? So during micturition process, we need to tell this pudendal nerve, boss, now you don't function. So when it stops, when this nerve is inhibited, that means it won't be putting any load on external sphincter. External sphincter is relaxed and the evacuation process starts, right? So that's how all of them, they will be working. This is normally contracted, right? Normally always contracted. Now see, as we are discussing this, let's add, because next we'll be starting head and neck and then the brain. So we can touch some of the areas. Just two things you need to remember. There is one cortical center, right? Higher. Then in pons, there is one Barrington nucleus. So they both, one is telling that, okay, let the micturition begin. But then that higher center tells, no, stop. You don't have to send this message, right? That's how things go. So when we say this cortical center, right? I'm taking it in very brief. This is the cortical center. And then in pons, there is that Barrington nucleus. right? That is what is called as the Barrington nucleus. And in fact, even in spinal cord, right, that is in the sacral spinal cord, there is that enough nucleus, S2, S3, S4, right? Even this pudendal nerve also, this is S2, S3, S4. So there are multiple. So let's write it. Sacral spine, right? So here also there is nucleus. Wherever there is nucleus, that means they can take control. But then someone is sitting on their top, right? So here it is this Barrington nucleus. He will facilitate micturition. He will say, yes, I'll plan everything so that person can relax. But on top of it, this cortical center is sitting. He is inhibitory to this Barrington nucleus, inhibitory to this pons, right? Which this cortical center that is into this frontal gyrus, second frontal gyrus, right? So second frontal gyrus. So he is inhibiting this pons, and that's how normally there is no micturition. Everything is under control. Right? Okay. When these higher centers are not involved, it is at that point. Why they should not be involved? Maybe say some spinal injury. So in that case, this sacral spinal nucleus, right, he takes over. And that leads to what leads to all sorts of, say, neurogenic bladders, right? We'll see that. So, but this is in nutshell. Now let's see it in slightly more detail. So when we talk about, say, nerve supply, right? In case of nerve supply, so we said that hypogastric plexus, right? We saw that hypogastric plexus. It will actually go in and form this vesical plexus, right? Vesical means something which is near the urinary bladder. And it is this plexus where everyone meets, right? Where everyone meets. So it is over here where the sympathetic plus parasympathetic, they meet. And then they enter into the bladder, urinary bladder. Right? So that's the whole idea, right? To be very specific, this would be like inferior hypogastric plexus. So for the parasympathetic, right? For the parasympathetic, they are motor, right? They are efferent, right? So they are efferent, they are motor, and they will be motor to detrusors, right? They will be motor to detrusor. So they will say whenever anything is motor, that means it will say, yes, do contract, right? Contract. When the detrusor contract, that means bladder would start emptying. True? Because it is the parasympathetic which will say, yes, let the urine flow. So that's the reason if this is destroyed, normal micturition won't be possible because that pressure won't be generated. Fine? So that's the parasympathetic, efferent motor to those detrusors. Okay. And yeah, if they are destroyed, normal micturition would be affected. Now, say for the sympathetic, their motors, right? What they will do, right? They are inhibitory to detrusor, right? They are inhibitory to detrusor. So it means detrusors, they will not contract. They will keep on relaxing. They'll keep on relaxing. When they keep on relaxing, there won't be any increase in intravesical pressure. The pressure in urinary bladder won't increase, right? If the urine is getting accumulated, so they will relax, they'll relax, they'll relax, right? So that pressure is not increased till that 250 ml reaches, because when the pressure sensation starts. Okay, so that's what really happens. At the same time, we talked about that there is internal urethral sphincter, right? We talked about this internal urethral sphincter or the pre-prostatic sphincter. It is this pre-prostatic sphincter that's where it will go and it will be motor to it. Now, as I said, whenever there is motor, right? Motor means it will say, okay, muscles contract. So, what was happening over here? Over here, parasympathetic, they were telling detrusors contract, so empty the bladder, right? Sympathetic, they are telling no, detrusors don't contract, relax, right? So, bladder capacity is increasing. So, urine is getting collected. But that urine can dribble out. So, then there comes the internal urethric sphincter, right? That internal urethral sphincter, this is motor. It will say, come on, internal urethral sphincter, contract, right? And that's how what really happens during matlab in normal course, right? Okay, now so far all good. Then comes, as we said, that there would be pain, right? There would be pain. So that's where the pudendal would come into picture. Pudendal and those sensory pains, because it will be carrying pain sensations also. So this is like somatic, right? This pudendal, or when we say it is voluntary, and it is necessary because S2, S3 and S4, what it actually does is it will handle that external or the distal sphincter urethra, right? Distal sphincter. Now this distal sphincter is under voluntary control. So that's what is to be inhibited if the urine is to be passed, right? Clear? And finally, there are sensory. So all of them, they will be carrying pain sensations, right? And these pain sensations, they are only when the bladder is stretched, right? So when there is distension, then and then there is pain. So that's the normal scene set up for the micturition, right? Now when we talk about spinal cord, right? In fact, brain and spinal cord actually will draw, right, and we'll be discussing every part in more detail, but right now we are not taking it just because of lack of time. But in spinal cord, just remember only one word, that is lateral spinothalamic tract, right? Because mainly spinal cord, right, parasympathetic and partly by the sympathetic, all those pain sensations, they are by lateral spinothalamic tract, because that's how the spinal cord is formed. Because everyone would come and then they will start traveling into the specific channel. This is nothing but like a conduit, like a pipeline. Those wires, they are going for the common destination on top, right? So that's why everyone is going into a separate pipeline. So it is a complete electrical system. That's how things are arranged, right? So this is for the pain, because their function is same. So every nerve, every fiber which is going, that is for lateral spinothalamic tract, that is for pain. But what if there is something which is called as the awareness of distension, awareness of distension. So it means when the accumulation is more than 500 ml, right, it is the lateral spinothalamic tract which will come into picture. But when it is in the range of about say 250, sorry, so when it is between 250 to 300, So that's where, if we are sitting in a bus, we start watching that when this bus is going to stop, because the sensations are going via that posterior column, right? Right. So if you're driving by car, right, you would like to stop at the nearest petrol station. So that's where the posterior column would come into picture. So next time, whenever you travel, right, just do take care of that whether it is the posterior column who is calling something, or whether it is the lateral spinothalamic tract, right? So that's how you can remember the things easily. Okay. Now here it is injury. This is very interesting. Injury to spine, what is called as the acute spinal shock, right? So whenever there is acute spinal shock, so immediately what happens, right? Immediately, as soon as there is some injury into this injury to the thoracic segment, one thing is clear, that all those bladder muscles, right, bladder muscles, they are relaxed now, because there is no one to tell them. Right? So bladder will simply become like a bag, right? So bladder distends. At the same time, those sphincters now they are relaxed. Sphincters relaxed. But say urine is not forming in a large quantity, it is forming at a very slow pace. So when the bladder distends, that urine, it dribbles, right? It urine dribbles in the small quantity, right? Urine starts dribbling into the small quantity. Now, post spinal shock, that is means after some time, say it is what is called as the spinal arc is established. Those spinal nucleus, right? They take over the control. They take control. And then, because of that spinal reflex, the bladder becomes hypertonic. That is, there is some tone in the bladder, right? There is some tone in the bladder, but its capacity is decreased, right? But now the bladder has got the strength, right? It can contract. So I'll write it over here in different color. This is, say, post spinal shock. That is when the spinal arc, right, spinal arc is established. So that is where the spinal reflexes would start. So what would happen? This spinal reflex will lead to hypertonic bladder. Now bladder has become hypertonic. It has contracted, right? So capacity decreased. Now, due to that spinal arc, this bladder will keep on collecting the urine, and then immediately it will contract, right? So its speciality is it empties suddenly, because there is spinal nucleus involved. When this thing occurs, this is what is called as the automatic, right? This is called as the automatic reflex bladder. Reflex bladder. It won't wait for the person's consent, right? It will empty suddenly. This is what is called as automatic reflex bladder, and bladder keeps on getting emptying itself at a regular interval, at a short interval, 1 hour, 2 hour, right? It will keep on emptying itself depending upon the condition. So this is what is called as the automatic reflex bladder. Remember, in that case, there is some tone in the bladder, right? Bladder is hypertonic and the small capacity. These two things are very important as compared to what if the injury is at a lower level? What if injury is at the lower level over here? Now, when injury is over here at such a lower level, right? Maybe say some, say, cauda equina lesion or spina bifida, right? In such cases, all those big bosses, they are sitting on the top, but they are now useless because this communication link is broken, right? So it means now we have got only the vesical plexus. Those vesical plexus, those nerves, only at a local level they are there. So only the local control is there. That is the local vesical plexus. They take over, right? They take over. When they take over, it means now even there is no spinal reflex, right? So that's the key thing. There is no spinal reflex. That means there won't be any tone, right? So the bladder will be flaccid, absolutely soft, right? It is, and when the bladder is soft, flaccid, right, it is just like a full big bag. So its capacity is increased, right? Capacity is increased. So urine would keep on getting collected, right? It will keep on getting collected. Bladder would be full. And then when the bladder is full, urine comes, urine gets filled, and then literally it overflows. It overflows, right? It overflows. And once that overflow starts, it is continuous dribbling. You got the idea? Because it is like the bladder is full now. Whatever the urine is coming, it is simply just going out. Because none of the sphincters are active, bladder just cannot contract. Because if the bladder can contract, right, fine, it has emptied itself. ठीक है, it has got less capacity, but even if that capacity is less, but it has to fill that much. So that was what was happening in automatic reflex bladder. Contracted, bladder emptied, now it is getting filled till the next action. While over here, this is a bag fully filled, even 10 ml is coming, 10 ml is dribbling. So that's the difference, and this is what is called as the continuous dribbling. This is what really happens in this case. And when there is this continuous dribbling, right, this is what is called as the autonomous bladder, right? So remember, this is called as the, or it is called as the autonomous bladder. Both of these topics, still there are so many different types of bladder, right? All those bladders, some overflowing bladders, etc. But these two are main, right? When in physiology or in medicine, when we'll be discussing, so the discussion would be in detail, but you should know at least this much very properly, that what is automatic bladder and what is autonomous bladder, right? So all these are the autonomous bladder. I've written it over here, but all these green things, they are for autonomous, right? Thank you. I'm happy for one thing. Means even if it becomes 2 hours, you guys just listen very patiently. I like that. Okay, now let's start with urethra. This is a very easy topic. Very easy, literally. Just everything is crystal clear that this is the path and how it really goes. Very easy. So let's start with male urethra, right? About 18 to 20 centimeters long, right? Let's divide it into two parts. One, which is posterior urethra, second is the anterior urethra, right? So one is the posterior part and second would be the anterior part. Posterior, yes, it is short, right? It is just short, 4 centimeters, right? Just over an inch. And this is this anterior part, which is actually long, right? The rest of it, so it is about say 16 centimeters, 16, 17 centimeters, that is the anterior part. And it is this part which would be divided into two. One will, what is called as the bulbar urethra. Bulbar urethra, it is, we'll just see, bulbar and the penile, right? The name itself is telling into the bulbar part and second is into the penis part. So these are the components. Let's see it, and no explanation would be needed, right? It is that good. What we already know: urinary bladder, prostate, we know that. Pubic symphysis, yes, we know it very well. Internal urethral sphincter, we have already talked about it, right? That is what is normally closed. True, right? Internal urethral sphincter, normally closed. And that is by sympathetic, right? Okay. External urethral sphincter, yes, this is also normally closed by pudendal, right? S2, S3, S4. So that is also done. Okay. Now about this part. Pre-prostatic part, right? I think we know this thing. Pre-prostatic, it is a small part. Pre-prostatic part, right? Prostatic trickle, day after tomorrow prostate would come. At that point we'll discuss, right? It is just a prolongation, but right now we'll not talk. The prostatic and the membranous part of urethra, yes, this is prostatic and membranous part of urethra. So there is see, there is a pre-prostatic part and prostatic and the membranous part, right? So what we are talking about is this part of urethra and this part of urethra. Fine. Bus to this, collectively they are called as the posterior part, right? Not at all difficult, right? The moment, see, that's the pelvic diaphragm. Pelvic diaphragm. So hope you remember that if there is any injury over here, so then that urine will extravasate into the peritoneal cavity. है ना? Now comes the anterior part. And this anterior part, it has got two portions. One, this is intrabulbar fossa, right? This one, this is intrabulbar fossa. And this one is the penile part, right? This one is the penile part, and this one is the bulbar part. So that is what would be contributing anterior part, right? So done, right? It's posterior part and the anterior part. From this point onwards, everything is like mathematics. So posterior part, pre-prostatic, right? Pre-prostatic. Yes, it was smaller, so just 1 to 1.5 centimeters, because the entire posterior part is about 4 centimeters. So this pre-prostatic, very small, right? And this pre-prostatic part, it has got, say, smooth muscles, right? These smooth muscles, they are similar to bladder neck muscles, right? They are similar to that. But these are detrusor muscles, right? Bladder neck muscles, they are the detrusor muscles. These are smaller than those detrusor muscles. So they are just acting like a very weak sphincter, but yes, it is a sphincter, right? That is what is called as the proximal urethral sphincter, right? Now, in this case, they have, just remember, adrenergic innervation. It is their own adrenergic innervation for this control, right? So what would be the purpose of this pre-prostatic part? One, the purpose, right? That's what we are really happy to know about. One is it maintains what's called as the continence. Now we could have written a very easy word, right? Let's write the easy word first, right? Simply, it prevents leakage, right? It prevents urine leakage. So what is this urine leakage thing, this entire thing? It is called as continence. It is called as continence. Incontinence means inability to prevent urine leakage. That is called as incontinence, right? So that's why in one word, when it is written like incontinence, that means urine is leaking. So that is first thing. This is the function of this proximal urethral sphincter. And the second important thing is, see where it is. It is at a junction, right? Say it is at a junction, right? It is at a neck, right? Over here, who is it? It is the prostate, right? From here, there is bladder. Now, bladder is not at all interested that ejaculate should be entering into the bladder. So it is this, because see over here the ejaculatory duct is going to come, right? So during ejaculation that semen should not be going up into the bladder, so that is the reverse flow of ejaculate that is prevented, right? So this is pretty interesting. So it prevents a reverse flow of ejaculate. So this is the posterior part, right? Let's see here. Pre-prostatic urethra, then that entire part up to here, that is collectively like prostatic urethra, right? Something which is into the prostate. So there is pre-prostatic urethra, prostatic urethra, and the penile part, right? Over here, that internal urethral sphincter. This is external urethral sphincter, right? These are the bulbourethral glands, right? Those bulbourethral glands, they will be pouring their secretion into the urethra, and then say these are all urethral glands, and finally the penis parts, right? Now there is one important pathology associated. Any damage in male, right? This proximal sphincter, right? Proximal urethral sphincter, this one, right? Proximal sphincter, it can be damaged in bladder neck surgery, even that cystoscopy, right? Bladder neck surgery or any of the say cystoscopy, or that is what is called as the TU resection, transurethral resection, right? We'll talk about it in when we'll be talking about prostate. TU resection of prostate, right? Especially in case of BUP, benign enlargement of prostate, how it is done. But the idea is that whenever something is getting done, if this is damaged, right, it matters. It won't matter because it is absent in females. So it won't matter in case of females, right? It is absent. So that is the full view. Let's move on to now the second part. Right now, say just to recapitulate, posterior part we are discussing, right? And we talked about pre-prostatic, and now we are talking about prostatic part, right? This was roughly 1.5 centimeter. So remaining, say 3 centimeters, about 3.5 centimeter, that is the prostatic part, right? So we are now dealing with prostatic part. Prostatic part, one thing to be known, the shape. It is like this. So all over here, right, it is this prostatic tissue. So that it is like a tube, right? But then it becomes crescentic, right? So this is what is called as the crescentic. That means half moon shaped, right? And that's the reason over here there would be something like, that's what is called as the urethral crest, right? Urethral crest. Urethral crest in prostate. So when we'll be studying prostate, we'll see that there is urethral crest, right? So that is where we know that, okay, it is this portion where the urethra that is like crescent, right? Now that crest on both the sides, there is a depression. That is what is called as the prostatic sinus. So all those prostatic ducts, they will be actually opening there, right? Because prostate, you know that it puts that nutritious fluid for those traveling sperms, right? So that's that's like urethric crest, right? That's like urethric crest. And on both the sides, there is small depression, and that's where all those ducts they are opening, right? So they are called as the prostatic sinus, and ducts open here. Obviously, the prostatic ducts open here. This would be still crystal clear when we'll be discussing prostate, right? And in between, right? So these are the ducts where the prostate will be putting. And in center, that ejaculatory ducts they are opening. So that's where the ejaculatory ducts will open. So those sperms, they are carried by ejaculatory ducts, and the nutrition is provided by the prostate, right? So from here the nutrition is provided, and from here the visitors would be coming. Fine. So just the words, right? The sinus, prostatic sinus, urethral crest, and the opening of the ejaculatory duct, which is called as the prostatic utricle, right? It is called as prostatic utricle. Prostatic utricle, right? So utricle in the center, then over here on both the sides there is sinus, and this is what is called as the crest, right? So that's the crest. On both sides of crest, these are sinus, and this is utricle, right? So ejaculatory ducts, prostatic ducts, right? And the whole journey starts. This is a very good figure conceptually, right? These are where the shapes of urethra, shapes of male urethra, how they really change. Starting with prostate, right? That is where it is crescent shape. So that is the urethric or the urethral crest, right? Then as it will go into the membranous part, this would be the shape, right? Then as it will enter into the penis, that would be the shape, penile part. And as it will reach final to the final opening, that is external urethral open orifice, it will be the oval but longitudinal, right? So these are the shapes. Now we move on to the anterior part, right? Anterior part. In anterior part, we do have two. One is the membranous part, right? Membranous part, and second would be the penile part. Now this membranous part, this is again short, least dilatable, and the narrowest. And this is where the external urethral sphincter that is lying, right? And you know that external urethral sphincter which is under voluntary control, right? So this is the membranous part and it is the narrowest. Right? So about 1.5 centimeters, and this is where the external urethral sphincter, that is what they. One speciality of it is that the muscles, right over here, these striated muscles, they are short and they are slow twitched. Now say you know that there are two types of muscles, fast twitching and slow twitching, right? Twitch. Say if you want to go for 100-meter sprint, so then you will require a fast twitching muscle. If you want to go for a marathon, so then you require a slow twitching muscle, right? When you want to go uphill, right, when the power is to be applied, so then you'll require slow twitching muscles. It is exactly like a gear system. When it is in the first gear or second gear, so your car will be generating more of the torque, right? More of the pump, and you'll be able to go uphill. When it is a flat road and things are good, so then it is the fast twitching, because when the gears they are smaller. So same way over here, these are like external urethral sphincter, they are slow twitch muscles. Slow twitch. So those who are good in mountain driving, right? When on mountains, normally you keep on shifting gears from first second, first second, first second. That's how the car goes, right? You won't be putting it into the fifth gear and then you'll go ahead. Urine discharge is controlled by, okay, we'll come to that. So the reason is that it's a huge topic, but yes, for the ejaculation, uh, we'll cover it in the male reproductive system. It is at that point we'll cover it. So this slow twitching, these are the intrinsic muscles. The idea is for the sustained long contraction, right? These are for sustained long contraction. Fast twitching, they are for short duration. So that's the reason these are slow twitch muscles, right? So they generate enough tone, and the idea is when the tone is generated, right? A good tone, so that means they will be able to maintain. Now we'll write only the technical term, maintain continence, right? And you know what is continence, right? It prevents leakage, right? Okay. Rest is all the external urethral components, rest of the components. They are like those levator ani, pubourethral parts, etc. Yeah. So levator ani, then we talked about this urethral striated muscles. Striated means they will be under voluntary control, right? All of them, they are meant for sustained contraction. But over here, this levator ani has got one very important function, and that is it resists raised intra-abdominal pressure surge. So it resists intra-abdominal pressure surge. Now what it is getting utilized for this external urethral sphincter. If this is weak, that means urine may dribble out, right? That is what incontinence is. Now see, on this page, I'm writing few exercises. These are called as Kegel exercise or the pelvic diaphragm exercise, strengthening the pelvic diaphragm. Whether male or female, these exercises, they are common for both, right? The first and the vital exercise, this is what is called as the bridge. I'll draw the figure and you'll be able to follow it very easily, right? So that's the thorax, that's the abdomen, right? And say hips, and these are the legs. That's the floor. This is what is called as the bridge, right? It will generate very good pressure onto the pelvis, right? To make these things still better, you can raise the hands in air, both the hands in air. Hold it for at least all these exercise. You don't have to go for any of the reps. Reps means repetitions, no reps, right? Because you are dealing with those slow twitching fibers. So for slow twitching fibers, you have to hold it minimum for 20 seconds. Minimum 20 seconds. Then and then the benefit actually starts. Second, you know what is squats, right? Squats is like the best description as if you are trying to sit on an invisible chair, right? So you are sitting on invisible chair. There is no chair, but you are just lowering your body, right? So that these knees are almost parallel. If you these are your hands, this is anterior. If you can go still lower, wonderful, right? Try to hold this thing for 20 seconds, right? I'm writing 20 seconds, but it is not easy to maintain it for 20 seconds, right? But if you can, it's okay. And with practice, you'll keep on increasing it. And third is, this is, say, on all four, right? Your hands, your legs, and then right hand and left leg. So the position would be something like, say, let's say this is left leg. So then right hand, right? One hand, your left will remain down. So it is like opposite, right? Left, and this is, say, right. So just crisscross, right? So this is left, this is right. So this hand and that's the leg, they are crossing and then they will come. So it is like elbow and the knee. Try to touch both of them and then do this thing for 5 times, 5 to 10 times, and then for the opposite side. That's it. These are three very effective exercises for strengthening of the pelvic diaphragm. And actually it is so important, right? Because that intra-abdominal pressure, right? That is what is raised in case of, say, coughing, laughing, right? Any of the exercise. And yes, this urine dribbling is pretty common in aged females, right? So that's where the all those adult diapers, etc., are needed. But the simple reason is the pelvic muscles, they are weak, right? So these exercises, they really help a lot. Okay. Finally, the absolute anterior part, right? That membranous part was the part of that posterior only, right? Actual anterior is this bulbar and the penile, right? What we saw into the figure. Right? So it is this bulbar part that is surrounded by bulbar urethra. That is the wide part, right? This is the wide part, what we saw in the figure. And the spinal part, this is the narrower. Okay. Regarding those arteries, the urethral artery, this would be the main one. And this will be from internal pudendal artery. This would be from internal pudendal artery. So this would be one, that is main. The second one, that is the dorsal penile, right? Dorsal penile artery. This is from that circumflex branches, but it is minor. This one is main, right? This one is from circumflex. Veins, they are very specific. For the veins, for the anterior urethra and the posterior urethra. Veins from the anterior urethra, they will be draining into dorsal vein of penis. From there, it will drain into internal pudendal vein, right? Internal pudendal vein. And from internal pudendal vein, it will drain into that final prostatic venous plexus, right? Now see this prostatic venous plexus, name itself is telling that it is the plexus around the prostate, this prostatic venous plexus. And from here, it will be draining into internal iliac veins. So this entire journey is for anterior. However, for the posterior, nothing much. It drains directly into the prostatic venous plexus because that posterior urethra is pretty near to prostatic venous plexus. So straight away it drains it over there. Some part may go into the vesical venous plexus. Right, vesical venous plexus. We saw that vesical venous plexus which was going via that posterior ligament, and that would once again will be draining into internal iliac, right? So that's the layout. Lymphatics, they are very, very easy. All of them, right? In fact, most of them, they will be draining into internal iliac, right? So it is this internal iliac lymph nodes where the prostatic part, after that membranous delicate part, right, they would drain. And it is this anterior part, that is the bulbar and the penile part, they will go into the deep inguinal lymph nodes. Okay. Yeah, topic is pretty long. But we are almost at the end. You see that there is, for the nerve supply, there is prostatic plexus. As we said, that there would be several plexuses into the abdomen and pelvis. So one of them is prostatic plexus. And this would be supplying to smooth muscles of prostatic urethra, right? Prostatic urethra. About the pre-prostatic sphincter, we know that it is bisympathetic because it is keeping everything under control, right? And especially during ejaculation, yes, we said that it prevents that reflux. So we already talked about it. So pre-prostatic sphincter, we just say that it is the sympathetic supply, right? Which are the nerves? Actually, they are called as the greater cavernous nerves. For the parasympathetic, S2, S3, S4, right? It goes to the bladder. And the striated, that is mainly by S2. Striated mainly by the S2. In case of female urethra, it is much smaller topic and much easier, because the idea is the whole length itself is just 4 centimeters long, right? Just 4 centimeters long. So nothing more, all the way from internal urethral opening into the bladder, urethral opening in bladder, and straight away it will be opening into the anterior to vaginal opening. Bas, that's it. This is the reason that catheterization is so easy. Just in between, there are small urethral glands which are present, and they will open into the common duct, right? So there are small urethral glands, and they will open into what's called as the para-urethral duct. Bas, that's it. Regarding all those arteries, veins, everything is similar. Only thing is, say, now there will be vaginal arteries. Otherwise, rest of the arteries, yes, they remain the same, right? It is the superior vesical artery, and instead of that inferior vesicle, there is uterine and the vaginal arteries. Veins, it remains same in the form of, say, vesical venous plexus, right? Vesical venous plexus. From vesical venous plexus, it goes into the internal pudendal vein, and this internal pudendal vein will finally landing into internal iliac vein. Okay. So same thing for lymphatics, all those internal and external, and the nerve supply is also similar, right? Everything with those plexuses. All we need to remember is that there is no internal urethral sphincter. That is not present. Otherwise, rest of the structures, right? Those external urethral, right? Urethral sphincter, that is again with the slow twitch fibers, we talked about it, and the levator ani. This is the reason that levator ani has got such an important role, right? Because it is what is forming that pubo-urethralis part, right? It is playing a major role for the sphincter action to prevent that urinary incontinence. Now, I think, what do you say? So there is still one topic left out, that is the entire process of micturition, right? And it would take good 10-15 minutes. So I don't mind. But if you have got capacity, so then we continue with that. Because as such, it's a part of physiology, right? The anatomy part is complete. So what do you say? You let me know. If you wish, yes, we can continue. Within 10 minutes, we'll be able to complete, right? And actually, I feel it would make sense to learn that thing right now. As we are just 20, so should not be a problem. You tell me. Maximum, it will take 10-15 minutes. Should we take that topic? All right, good. That is good. Very nice. Oh, wow. Brave soldiers. See, that's what I like so much. Very nice. All right. So now this is process of micturition. Actually, it is summing up the whole thing, right? So here the process starts. See, bladder, urine is getting formed, right? Urine is coming. Drop by drop from both the sides, both the kidneys are functioning. Bladder fills. Bladder fills. Bladder is said that no, don't contract. Why? Because it is this sympathetic system. Sympathetic system is telling that no, 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 you don't have to contract, right? Relax. Just keep on getting. So detrusors relax. So detrusors they relax. Bladder size increases. Intravesical pressure is not increased. In fact, it remains the same. And then there is no pain, right? Bladder fills, distends. When bladder distends, intravesical pressure is same, so that there is no pain. This process would continue till about 220 ml to 250 ml. Now, at that 220 ml or 250 ml, detrusors would say that now we cannot relax more, right? So, kidneys are working. So, now starts there is increased intravesical pressure. That pressure rises. When that pressure rises, it would stimulate those sensory nerves, right? Sensory nerves. See, still there is no pain. It is just the desire to micturate. That's the point when we start looking out of the window. यार कोई nearest petrol station आया कि नहीं, right? That is desire to micturate. Those posterior columns, right? They are now sending signals to brain. Conditions not suitable, right? That bus conductor said after 15 minutes, right, we'll be stopping. All right, right. And it, this sympathetic system is working, right? Pressure is increasing. And when it crosses, right, say 500 ml, now the pain would start. That is where those lateral spinothalamic tracts, they will start sending message to the brain that now shout on that bus conductor that it is too much, right? But still say thanks to that external urethral sphincter, right? It is that pudendal nerve, right? Which is working constantly, no problem, right? Hang on, right? So this is S2, S3, S4. And finally, that bus stops, right? And the situation is comfortable, and that is where the voluntary voiding of urine occurs. First thing first, that external sphincter urethra, that is a pudendal nerve is told that you have worked enough, now stop it, right? So it is this external sphincter that relaxes. Joint effort of all those perineal muscles plus abdominal muscles, they generate the pressure, right? And now we need also one more thing, that sympathetic system, right? Now you don't have to work. So that means that inhibition on detrusor, it is not there. Someone who was inhibiting the detrusor is not there. So now detrusors, they become active, right? They contract. And that leads to the entire process of micturition, right? So that's how this entire process would really roll on, right? Okay. In this process, abdominal muscle contraction, that would take part, detrusor contraction. But in case of males, you know, there was a muscle called bulbospongiosus. This was one of the muscle, paired muscle, which was attaching to that perineal body. The function of this bulbospongiosus is, it is to expel last drops of urine. That's the idea. In case of female, because the entire urethra is very small, right? So there is never such a problem. But in this case, the bulbospongiosus, to expel last drops of urine, because that was the urine which was into the bulbar portion, right? Into the bulbar portion of urethra. So you remember that bulbar portion, right? This bulbar portion, and then the penile portion. Penile portion, so that's okay. It's a narrow slit, so immediately it will be emptied. But some urine, it should not be getting collected over here. So that bulbospongiosus, it will contract, right? And it will push these last drops and it would be emptied. Imagine how sophisticated the entire system is done, right? How technically so sound everything is. Now see, once done, right? Now the detrusors, they would relax, right? So first detrusors will relax. Then the proximal urethral sphincter, right? That would contract, correct? So first block. And finally, the distal urethral sphincter, that contracts. So done. Back to original journey, and this occurs in that order, right? In that order, the whole thing works. And then back to the journey, kidneys are functioning, and it is constantly working, right? So yeah, this is that figure what I was. So that's what is called as the catheterization. So in case of catheterization, say these are the catheter, right? This is the inflated balloon. So normally it is like a tube. In fact, it is a double tube, right? It's like a double tube. So because if it is like this, right, if it is inflated, so then it can damage the entire area in between. So it is not so, it is just like this tube, and it is inserted into the penis and that catheter, and it follows and it finally reaches to the into the bladder. Then from over here, right, from this point, right, so water or saline, right, that is injected. So this balloon inflates. So then it is pulled back. So now this catheter is locked. So it won't be accidentally pulled out, right? So that's the meaning of this inflated balloon, and that's the catheter. From here, the urine bag is attached, and urine keeps on getting collected. The complications could be one, false passage. Because it can really damage. There can be infection or the urethritis, right? But usually it can be avoidable, and in case if there is any injury, may lead to bleeding, right? These are some of the complications, but otherwise this is a very common procedure, and normally it won't pose any of the problem. In case of female, it is absolutely easy because the catheter is also different, and as the length itself is just 4 centimeter, it is just a matter of just putting it in, right? So that's it for today, right? Thank you so much. And do let me know that should we continue with it in such a way that I keep do write some of the topics. I mean some of the material right beforehand so that we can save some time and we can go ahead with the proper explanation of when it is needed, right? And I asked something else, but I don't remember right now. Okay, anyway, thank you so much, and we meet tomorrow. Okay, bye bye and good night.